gentlemen, it wouldn't be dubious to suggest that our next speaker is a global authority on lupus. Dr. Michelle Petri completed her medical degree at Harvard University School of Medicine. This was followed by a medical residency at Massachusetts General Hospital, Boston, and 2 fellowships at the University of California, San Francisco. She is currently serving as a professor of medicine at the Johns Hopkins University School of Medicine. Dr. Petri is the director of the Hopkins Lupus Cohort, a longitudinal study of morbidity and mortality in SLE, and she is also the co-director of the Hopkins Lupus Pregnancy Center.
As a well-renowned researcher, Dr. Petri's work revolves around improving the quality of life for systemic lupus erythematosus patients, which has led to her being dubbed as a guiding light for lupus patients. Ladies and gentlemen, please put your hand together for Dr. Michael Petri.
Hello, I'm Michelle Petri. I'm very happy to be able to join your 26th conference virtually. I'm going to be giving an update on lupus nephritis. Here are my disclosures, but I don't think you're going to find any of them relevant. End-stage kidney disease is a very real problem in the cohort that I follow at Hopkins. If we look at all of my patients, almost 10% will be on dialysis within 20 years of joining the cohort. It's even worse for those who were diagnosed with lupus nephritis within their first year of lupus. For them, in 20 years, 23% will be on dialysis. We do know what the risk factors are: being male, African American, being diagnosed in the pediatric years, or having low complement or high anti-DNA. Of all of these risk factors, low C3 is the strongest. If we look outside of Baltimore and look at data from the entire United States, this was a study that Michael Ward from NIH did, and it was during the mycophenolate era, but very disappointingly didn't show any reduction in end-stage kidney disease. In addition to showing the greater risk in African Americans, it also showed the greater risk in Hispanic Americans. We do know that lupus nephritis is an independent risk factor for mortality in our patients. Here is a study presented by Ram Singh at the ACR plenary session 2 years ago. Using a large national database, he showed that there had been a reduction in deaths from lupus nephritis until 2015. But from 2015 to 2020, so pre-pandemic, there had been an increase in deaths. Now, I think this is proof that the mycophenolate era is not sufficient to treat lupus nephritis. We're going to have to do more and do better. Now, why aren't we doing better? This is a message that was taught to me by Professor Anders, a German nephrologist. And his take-home message is that nephrons once lost are gone forever. So basically, lupus nephritis is chronic kidney disease. And this is because at the time of diagnosis, our patient has already lost 1/3 of her nephrons. Now, you and I are the blue curve. As we get older, we will gradually lose nephrons and podocytes, but we'll still have enough left at age 100, I hope we all get there, that we won't be on dialysis. A patient with lupus who does perfectly is the middle red curve. She will lose 1/3 of her nephrons at the time of diagnosis, but then if she quickly goes into a renal remission and never has a flare, she'll still be okay till about age, 85 or so. But our patients don't go rapidly into renal remission, and most of our patients will have a renal flare. So our patients are the bottom red curve. They take that initial deep dive, and then it takes a long time to get a renal response. The patient may have a flare and lose another large proportion of her nephrons. And so Professor Anders' take-home message is that most of our lupus patients will be on dialysis by age 70. So what is our goal? Now, we have to be more aggressive. Our goal should be renal remission, meaning back to normal. And then the second goal must be never have a flare. So we need to be checking the urine protein to creatinine ratio often. In my lupus nephritis patients, it's at least every 3 months. We must check on adherence. We need to recognize that lupus nephritis itself does not cause pain or other symptoms. And our medications can have unpleasant side effects, especially gastrointestinal. So many of our patients decide to stop medicines because they don't perceive the benefit. We need to educate them about the fact that if they do this, the loss of nephrons that occurs will be permanent. In addition, we have to treat these patients like we would treat anybody with chronic kidney disease. No NSAIDs, no CT contrast, no proton pump inhibitors, and a low-salt diet. So what is our goal for proteinuria? Our clinical trials have always used the definition of complete renal response as 500 milligrams or less. Now, there are data that if we achieve this, the patient will do better. But it is equivalent to telling a patient with cancer that our goal at 1 year is to leave them with some cancer. It doesn't make any sense. Our goal should be renal remission. But we have to be careful. Proteinuria is the best marker we have right now. But the nephrologists have taught us through studies of protocol repeat biopsies that 30% of the time there is still histologic activity when the proteinuria is under control. Now, we can't do kidney biopsies frequently. They're too invasive, they are expensive, so we must develop non-invasive ways to track renal activity. This is what we've been working on at Hopkins. Here's one of our initial studies of the urine proteome, and 3 urine proteins were highly associated with the same day kidney biopsy activity index. One of them, interleukin 16, that you see here in pink, no one even knew that was a player in the kidney until the work of Dr. Fava in our group. This has subsequently been validated by a second study of same-day kidney biopsies. And so we hope that someday it will be possible to know what the kidney activity is just from screening the urine proteome. Now, right now, you're very comfortable with the first 5 steps in treating lupus nephritis. But please remember that the voclosporin phase 3 study has changed how we do number 5, steroids. In the phase 3 trial, the patients were only given 20 milligrams of prednisone and had a required taper down to 5 milligrams. Please remember the EULAR criteria also emphasize the need to taper it down quickly. So if you're starting at more than 20 milligrams, please change to follow these new guidelines based on data from phase 3 trials. But I wanted to emphasize why we need to embrace the two newer therapies, belimumab or calcineurin inhibitors, either tacrolimus or voclosporin. Now remember, I really want to aim for renal remission, and that's what you see in this 10-year follow-up of patients who are in a lupus nephritis trial. Those that achieved renal remission on the left, 10 years later, really nobody was on dialysis. Those that just had a response, well, over half ended up on dialysis. So you can see remission should be our goal. And then on the right, you see those patients that had no response. And of course, nearly all of them ended up on dialysis. So I want to change the paradigm of how all of us treat lupus nephritis. The paradigm used to be very simple. Mycophenolate, 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 with the exception of pregnancy when we shifted patients to azathioprine with or without tacrolimus. But if you just use mycophenolate, the complete response rate at 1 year is only about 25%. And of course, remission would be much less than even that. So what are we going to do? At the time of the biopsy, if the biopsy shows very high activity, then I recommend adding one of the newer therapies, either belimumab or a calcineurin inhibitor, right then. But if at 3 months there's not a 25% reduction in proteinuria, certainly add one of the therapies then. At 6 months, if there's not a 50% reduction, add one of the newer therapies then. If you add one of these newer therapies, you should be able to get a complete renal response rate of about 40% at 1 year. Now, of course, that's nowhere near we want it to be, but it's better than mycophenolate alone. Now let's go through these two new therapies so you feel comfortable with both of them. Now, first will be the belimumab, phase 3 lupus nephritis trial. As you know, belimumab is basically an antagonist of BAFF, a B-cell survival factor. On the left, you see graphed the percent of patients who reached 750 milligrams or less, and on the right, 500 milligrams or less. Obviously, I prefer the complete renal response curve on the right. This is a 2-year trial, and the comparator is mycophenolate or urolupus cyclophosphamide. At 1 year, you can see a 6% differential in reaching the goal, and at 2 years, over 10%. Let's look at subsets. Belimumab had benefit for proteinuria in all subsets except for pure class 5. But now I want to go over the special strengths that belimumab brings to the treatment of lupus nephritis. And this is a story of protection. The only reason to treat lupus nephritis is to protect the GFR, to prevent dialysis. Belimumab protects the GFR starting at week 20, as you can clearly show in this graph. This protection went on for the full 2 years of the trial. The second way that belimumab protects is it prevents renal flares. And here you can see the point estimate is favoring belimumab for every subset, including class 5. There is a second biologic in the B-cell family that is being studied, and this is obinutuzumab, already approved for oncology indications such as lymphoma. This is a better B-cell depleter than rituximab. You'll remember that rituximab had no added benefit over standard of care in the LUNAR lupus nephritis trial. Here you see the 2-year results of the NOBILITY trial, where there is a 25% differential in the complete renal response between obinutuzumab and versus mycophenolate alone. Now, the next class of FDA-approved therapies is voclosporin, but you may be using tacrolimus instead, and we believe tacrolimus has exactly the same benefits. The advantage of voclosporin is simple pharmacokinetics, so it is a fixed dose, 3 capsules twice a day. To the right, you see the complete renal response at 52 weeks, with about an 18% differential between voclosporin plus mycophenolate versus mycophenolate alone at 2 grams. The key point here is the speed of onset. So the benefit on voclosporin in reduction of proteinuria starts at 1 month. Now, voclosporin both affects podocytes and T cells. It's probably more likely that this initial benefit is due to its effect on podocytes. Now, there are some updates on voclosporin. First, in a long-term extension that went on for 3 years, there was no loss in GFR. And secondly, in a subset that underwent kidney biopsy, there was no evidence of calcineurin nephrotoxicity. But this is, of course, still short-term follow-up. We really don't see calcineurin nephrotoxicity in transplant patients, for example, until about 10 years into therapy. There is the possibility that there will be another biologic for lupus nephritis. And the background for this one, anifrolumab, which is the anti-interferon receptor biologic, is that there is an interferon gene signature in some lupus kidneys. In this phase 2 trial, there was no benefit in the all-comers, but in a subset who received a high-intensity dose, there was numeric benefit. And it is this high-intensity dose that is being studied now in the phase 3 trial. Now, it may surprise you that I'm even bringing up CAR-T, but this was the initial patient with lupus treated with CAR-T, published in the New England Journal of Medicine. Within a month of the CAR-T, the disease activity was gone, except for some anti-DNA that remained. And this patient has now been followed up for 3 years and has remained in renal remission. Professor Schett from Germany has now treated a total of 7 lupus patients, and all are in renal remission, although one is still making anti-DNA antibodies. Now, why is this important? Because no one has seriously talked about achieving renal remission for nearly everyone with lupus nephritis. We have accepted a 40% complete renal response as being much better. But what if we were talking about nearly 100% renal remission on no therapy? That would be a revolution in lupus. Now, CAR-T is problematic. As you are aware, there's some initial toxicity, including cytokine storm and the potential of ICANS, neurologic toxicity, such as seizure, encephalopathy, and coma. There have only been rare levels of this in Professor Schett's work. Then, during the period of B-cell depletion, there is a risk of infection. He's enrolled patients that I think are incredibly healthy. My patients with lupus nephritis, I think, have much more comorbidity and would be at greater risk for infections. The cost is astronomical, $370,000 per course per patient in the United States. And obviously, if the lupus came back, because after all, the patient is genetically predisposed, has a microbiome that activates their immune system, and may be exposed to triggers like ultraviolet light in their future, well, then you'd have to treat the patient again and would want to have some way to have their CAR-T cells frozen away so you didn't have to engineer them all over again. So this is going to change how we feel about lupus nephritis. knowing that remission is achievable, I think we're going to hold all our therapies to much higher standards, and we'll want to know remission results, not just complete renal response results from all lupus nephritis trials. Now, our patients with lupus nephritis have lots of comorbidity. And so the arrow in the arm of St. Sebastian is probably the hypertension. The two arrows in the heart are the cardiovascular events, because lupus nephritis is an independent risk factor for cardiovascular events. And of course, the lower arrow is into one of the kidneys, because as you know, we can't save the kidneys in all of our patients. We're going to continue to be very interested in the work that's coming from nephrology on SGLT2 inhibitors, but there wasn't a single patient with lupus nephritis in these trials. But what we do know about SGLT2 inhibitors is that they tend to work better in patients who have ongoing proteinuria. So we may be thinking about GFR protection in the future, not just from medicines like belimumab, but potentially from SGLT2 inhibitors as well. I want to thank you very much for your attention.
Thank you, Dr. Petri. It has been an absolute privilege having a leading authority like yourself join us today. Ladies and gentlemen, now Dr. Michelle Petri will be taking any questions. Do we have any questions for Dr. Petri? We request our volunteers and facilitators to arrange free mics for the audience in case anyone has a question for Dr. Petri. Go ahead, sir.
Thank you, Dr. Petri, for giving a nice talk on lupus nephritis. I'm Dr. Taber Rasool, working as a rheumatologist in Dow University Hospital. My question is, you elaborately discussed about the interleukin-6, its role as a follow-up for the treatment of lupus nephritis. My question is, does interleukin-16 correlate with the disease activity of the lupus nephritis, and what are the other conditions that interleukin-6 may be increased apart from the lupus nephritis? Thank you.
Our work on the urine proteome, and that's work done with Dr. Andrea Fava, has shown that there are markers in the urine proteome that correlate with the histology of a same-day kidney biopsy. Interleukin-16 is one of them. And in fact, interleukin-16 is one of the most prevalent inflammatory cytokines in the kidney. So we find it in the urine, but it's definitely present in the kidney. So the urine proteome is a direct look at what's happening in the kidney. There isn't any therapy directed against interleukin-16 yet, and that's because Dr. Fava just discovered it a couple of years ago. Another marker in the kidney that we can track in the urine is CD163, which is a macrophage marker. And I don't think it was until the Accelerated Medicines Partnership, or AMP, that it was really well accepted that macrophages are part of lupus nephritis. But we don't have any target therapy for CD163 either. Several of the other markers that Dr. Fava has found, and these will be presented at the ACR meeting next month, are likely neutrophil markers. And if you think about it, maybe the prednisone that we used for so many years to treat lupus nephritis was getting at the neutrophils, but with too high a price. We don't want to depend on prednisone in high doses to treat lupus nephritis anymore.
Can you a bit elaborate this? Does IL-16 correlate with disease activity, or can tell about the class switch of lupus nephritis?
So interleukin-16 is the urine proteome marker that best correlates with the histology, meaning the NIH activity index. But a panel of about 5 or 6 of these urine proteins will be the best way in the future, in the clinic, to track what's happening in the kidney. And our goal would be not to have to do kidney biopsies anymore, because we would be able to track what's happening in the kidney so accurately from the urine proteome.
Thank you so much. Thanks.
Hi, good morning and good evening for you. Dr. Petri, always a pleasure listening to you. Aisha here from Singapore. I have a question about combination therapies. There's some literature coming about combination biologics like sequential rituximab, belimumab. Would you like to comment on that?
So I hope we're still connected. I can no longer see the meeting.
Yes, we can hear you and see you.
Okay, good. Okay. So I'm glad you can hear and see me because I can only hear you. But I wanted to say how wonderful it is to see Dr. Latif, who did a fellowship with me. But yes, I think combination therapies are coming. But I don't think it's going to be sequential rituximab and belimumab, or belimumab followed by rituximab, which has also been studied. I think the most logical combination right now is to have triple therapy. And I mean by that mycophenolate, but belimumab and a calcineurin inhibitor as well, because they all bring different strengths to the table, as you heard. So I think that the belimumab is going to bring protection of GFR and prevention of renal flares, and the calcineurin inhibitor will bring quick reduction in the proteinuria. Because proteinuria is just bad. You know, it's bad if you have hypertension. It's bad if you have diabetes. Intervention studies in other diseases have been able to show that reduction in proteinuria leads to better GFR. So if we had triple therapy, I think our patients would do better. But I must tell you, I have many patients on triple therapy who still do not achieve even a complete renal response. Basically, I think telling us that eventually we're going to need to have some sort of biomarker to help us pick the right set of medications, whether they're biologics or not, for each patient.
Thank you so much.
Hello, Petri. This is Dr. Tahira Parveen. I have been coordinating with you for this talk. We met last year at ACR, and thank you so much. We are honored to have you here at this, odd hours. I mean, it's pretty late at your place. So my question, which is not related to this talk directly, once we met at a conference, and I asked you, rather you presented or discussed about need of dividing the dose of Clexane during pregnancy in patients with APS. Although we do not have any data on it, direct data, but I started following your lead, and my patients are doing very nice, mashallah, alhamdulillah. So we have been able to rescue pregnancies in patients who were never able to save their pregnancies. But again, in this era of evidence-based medicines, saying that Dr. Tahira is doing this will not satisfy others, curiosity and all that. So could you please elaborate on it? Although I have found it very effective in my patients. Thank you.
Well, thank you for that question. So the first issue is, what is the half-life of low molecular weight heparin? And it does not have a 24-hour duration of action. So I think it's obvious scientifically that we must protect the placenta for 24 hours out of 24. But in addition to my own personal experience, the randomized clinical trials that have been done of treatment of APS pregnancy with heparin and aspirin got different results. And when you look at the major ones, most of the ones that showed that heparin and aspirin worked used low molecular weight heparin twice a day. And some of the trials that did not show that heparin worked used it once a day, such as the Farquharson trial. So I think you can make a very strong case for twice daily dosing based on the randomized clinical trial experience. But of course, we know that heparin and aspirin doesn't work in all APS pregnancies, and people have wondered what should be added next. There's actually a trial ongoing in the United States, headed by Jane Salmon and Ware Branch, of adding an anti-TNF that does not cross the placenta. And I've thought this was particularly brave because I think many of you are aware in rheumatoid arthritis, for example, anti-TNF therapy can increase antiphospholipid antibodies. But it is true that TNF is a downstream part of the inflammatory cascade started by antiphospholipid antibodies. So that's the rationale to do it. So we're going to have to wait for results of that study, which is going to have a small number of pregnancies in it, to see if maybe that will be the next place to go. Though, if someone fails heparin and aspirin, add vitamin D and hydroxychloroquine in the next pregnancy. Our work on vitamin D, though, has shown that the 25-hydroxy vitamin D level in pregnancy needs to be between 40 and 60. Too little, there's an increase in adverse pregnancy outcomes. Too much, there's also an increase in adverse pregnancy outcomes. There's a therapeutic window. It just shows you how complicated the immune system is in pregnancy.
Thank you so much. Again, Dr. Petri, I appreciate your input and appreciate your presence at this late hours. If there are any further questions, we will email you, and we look forward to seeing you again at ACR, inshallah, next month. And thank you so much.
Good evening, Dr. Petri. I'm Dr. Sarah Ismail from Indus Hospital. I wanted to ask two things. One, patients who you've put on triple therapy as compared to double therapy, as you mentioned, you haven't seen complete renal response, but what about clinical progression? Is it quicker in triple therapy as compared to dual therapy? And the other question is, what is your criteria for choosing a patient when he first presents to you to put them on triple therapy? And why not dual therapy?
So I'm not smart enough to know who needs triple therapy at the time of the biopsy. KDIGO and EULAR have come up with rules that if the person at 3 months doesn't have a 25% reduction in urine protein, we should add something then, but they don't tell us what to add. It could be a calcineurin inhibitor, it could be belimumab. And at 6 months, if there's not a 50% reduction in proteinuria, to add something then. But again, they don't tell us which one to add. You can see there's a terrible bias in my patients who are on triple therapy. It's because they've been doing very badly. So I haven't done a randomized clinical trial to see, who needs it. Are people going to do better long term if I started at the very beginning? I think we need to do that, but it would take the academic community basically banding together and designing it in a way that we could enroll patients in our different countries. I think that will happen. I think the idea of having triple therapy is something people are very interested in, but I think I agree with your point. We really should be using that at the very beginning. And again, at the very beginning, we're not sure who needs it.
Thank you.
Thank you, Dr. Petri, for your valuable time and very informative presentation. I think the newer forms of treatment have revolutionized the picture in lupus nephritis, which was considered to be, especially the proliferative form with crescents, was considered to be a death warrant for the patients. But the newer forms of treatment have changed the prognosis. But definitely the cost factor matters for us. Now, CAR T-cell therapy with the cost of 3,70,000 per patient, the patient would have to go to IMF for that, I think. But definitely newer forms of treatment are coming up and changing the picture. Thank you very much, Dr. Petri, for your valuable time which you have given to this conference. Thank you.
You're welcome. Bye-bye.
Right, Dr. Petri, thank you. My name is Dr. Kamran. I was very impressed and inspired by your talk. Is she still there?
I think Dr. Petri has just left the call, sir.
Okay, but the message to the audience is something very important. I think her talk highlighted the need for being more aggressive, and as the theme for this conference is mission is remission, even in lupus nephritis we have to aim for the best possible outcome. We also note that there are easier ways to look at disease activity in the kidney rather than going for biopsies. That's a very promising area, and people like Javed and all who have special interest in nephrology as well would like to follow that and see whether disease activity could be followed by urinary protein analysis rather than renal biopsies. So I think there is a good future ahead. The pharmaceutical industry will have to look at making more drugs available for us to achieve this outcome, cheaper and within the reach of most of our patients. Thank you. We'll invite the next speaker. You can go ahead with that.
Thank you, Professor Hamid.